Good.
Once again, beginning of the fellowship year, thank you guys for um, joining in. We have a pretty fun lineup for the year. As you know, our conferences will be, a split between some of our homegrown faculty, the fellows giving talks, but then we have the great opportunity now of having people from all over the world basically teach us on areas where their expertise shines. And this holds true for sure for Mike Kelly, who's here local in San Diego at Rady, but has done a ton of work in the world of the sagittal plane and where our alignment targets really ought to be, and has influenced many of us in how we do these operations. So real excited to have Mike teach us this morning, and it's a pleasure and honor to have you, Mike, and let you take it from here.
Great, thank you. We got a half hour, so I got a motor. Closures. So we'll talk about sagittal plane development. What's that? Development of sagittal plane, understand balance and economy of the sagittal plane, and then to go over proposed alignment schemes and their potential limitations. So our sagittal plane development, right? Apes, we are descendants of apes. Apes have a globally kyphotic spine. See that we are bipedal, and that is where our acquired sagittal plane features come from. We develop in kyphosis, in uterosis. And then as you mature, you become mobile and you do tummy time and you get some cervical lordosis in an effort to see the horizon. Then you start to crawl and you get some lumbar lordosis. And it's really with bipedalism, where you are upright and walking, that you acquire your sagittal curvatures, right? And so the primary sagittal curvatures are thoracic kyphosis and sacral kyphosis. So everything starts as kyphotic and they remain kyphotic. The acquired curvatures are cervical alignment. I need to change this slide from cervical lordosis to cervical alignment, lumbar lordosis, which are responses to your pelvic incidence. Your pelvic incidence grows or changes through skeletal maturity. So if you look at the papers that talk about where they have x-rays of 4-year-olds and 8-year-olds, 10-year-olds and 12-year-olds, it's really not until you're 10 or 11 that your pelvic incidence is really stable. And that is because your pelvis is growing in the A to P direction. And in some people that will change their pelvic incidence. Sorry. And as we grow and mature our sagittal plane curvatures, we mature into what Dubusse called the cone of economy, right? Which is an upright posture, extended hips and knees, your head over your hips and knees, where you are not doing work, right? You are minimizing energy expenditure and could theoretically stand upright for quite some time. And as the fellows have seen in their residency programs, and you'll see this here in the practices, as people degenerate, they can, but not always, begin to have pain secondary to their sagittal plane. That is in both like de novo situations and infusion situations. As you are fused out of the cone of economy and become an iatrogenic deformity, then you also add the risks of pseudarthrosis, proximal junctional kyphosis, and decreased health-related quality. Things to think about is first in AIS, where most of my practice is now, I'm not sure we have any idea what to do with their thoracic spines, right? Everyone in my world now talks about restoring thoracic kyphosis, when in reality, they probably never had a normal thoracic kyphosis. So I'm not sure what we're restoring. We don't know what the targets are. We, I think, take a number of people well balanced to out of balance because they have developed their sagittal curvatures in the setting of a coronal plane. The other thing to consider is that when you operate on people that do not stand, they only sit, for example, neuromuscular scoliosis, or maybe you'll see a Charcot arthropathy this year, you do not want to nail your lumbar lordosis targets in those patients because we flatten our spines when we sit down. In general, irrespective of pelvic incidence, the lumbar lordosis for sitting adults is between 25 and 30 degrees. And what you'll see, especially in neuromuscular scoliosis, is that some of them are 70, 80, 90, 100 degrees, and they're hard to fix, and the implant companies will sell you these pre-contoured hyperlordotic rods. That's the worst thing you can do. The goal of that surgery is to remove that lumbar lordosis. lumbar lordosis after surgery is one of the few things I think was reasonably shown in the Horton Study Group CP study as being related to a poor outcome. So leaving the cone of economy, right, it's a frequent indication for surgery, but it's not ubiquitous. And we need to be careful with that. The patient on the left there is a degenerated older patient with no symptoms. And then the other one is clearly someone who has had symptoms, multiple surgeries, now has pseudarthroses. And you don't need to go operating on people that don't have symptoms, but when they do have symptoms, you got to get it right. The first sagittal plane classification system that I think is important to understand and think about is the SRS Frank Schwab classification. It really recognized the importance of the pelvic incidence. It also sought to provide the much desired categories and simple equations that we want as spine surgeons, particularly that we're out there. And it provided target alignments, though I would say that PI minus LL, SVA, PT are all really highly correlated. And the high correlation means that as one goes up, the other one goes up. So it's not really that useful. It's worth noting that SVA, which is their measure of global alignment, is a terrible measure of sagittal plane alignment. You can have a low SVA with a pelvic tilt of 35 and lots of retroversion, or a low SVA and a pelvic tilt of 9 and be perfect. It also failed to recognize that your pelvic incidence lumbar lordosis mismatch changes as your pelvic incidence changes. So a PI of 40 on average would have a lumbar lordosis between 50 and 55. And a PI of 70 on average would have a lumbar lordosis of 72, so almost on the button. And if you are a 30-degree lordosis for 40-degree PI, that's going to be a pretty marked flat back. There's also, and this is an old classification, it's good to know and understand, but it's old. We need to move on from it because this is not the path forward for precision medicine. When you categorize continuous variables, it leads to misclassification. So if you tell me that a PI minus LL mismatch of 9 is different from 1 of 11, we could debate all day about whether or not that's true. I don't think that that's true. Or 3.9 and 4.1 for doesn't make any sense. Furthermore, if we're doing surgery, then the goal is quote unquote normal. The problem is that the median isn't the message. Stephen Jay Gould was an evolutionary biologist who was diagnosed with peritoneal mesothelioma. And went in and said, what does this mean? Like, how much longer do I have to live? And the doctor said, well, on average, 8 months. And he was smart enough to understand statistics and say, I don't care what the average is. I need to know what my number is, right? And averages are nice abstractions that we can use to write papers and things like that. But as we move forward, classifications and averages are not what we need. We need prediction models that offer probabilities of outcomes. The next, I think, important one to consider and think about is the Rousseli classification. They understood the relationship between the pelvic incidence, or as they went by sacral slope. I think PI is probably better because it's fixed. Sacral slope is a postural measure, and standing alignment. And looking at a cohort of 160 asymptomatic volunteers, they described 4 distinct sagittal profiles. So again, think about what I just said, that now we are back to categories, classification. It was later refound into 5 subtypes, and it was based upon the sacral slope of the patient, as well as the shape of the lordosis, and what they termed functional lordosis, which doesn't really make sense as a word to me. But understanding that the notion of measuring L1 to S1 for lordosis is only true for people whose inflection point between a lordotic segment and a kyphotic segment is T12 L1. If your T12 or if your L1, L2 is a little kyphotic, as in a Rousseli type 1, then your lordosis arc is actually L3 to S1. Or if you have a very high PI, your lordosis arc can actually be T11 S1. And it's this idea of both the shape and magnitude of lordosis changing that I think is very important. Here's the classification. If you go from left to right, this is increasing pelvic incidence, where this green line is right around 55 degrees. And if you present this at a meeting, and Frank Schwab will criticize it and say it's categories. Well, I mean, that's a little bit of the pot and the kettle calling each other black, right? But Schwab classification is all categories also. I think it's important to consider that this is all a continuum. And if you can see that this is a continuum in your mind's eye, you're going to be a whole lot better off. That from lower PI, at low PI, you have a very short arc of lumbar lordosis, and then a sweeping kyphosis above. Put C2 or the skull over the head. As your pelvic incidence increases, the arc of lordosis becomes longer, which means that the apex moves rostral. And the thoracic kyphosis will be less in the type 2 to balance this little arc of lumbar lordosis they have. As you get to 3s and 4s, it's just more of the same. The lordosis is becoming larger to accommodate pelvic incidence, the higher pelvic incidence. The apex is moving slightly more rostral, and this is where you get the arc of lordosis that goes T11 to S1 in the type. With more thoracic kyphosis as a response to this lumbar lordosis and pelvic incidence to head into the correct place. Things to consider is that there's also, and you will see these in adolescent idiopathic scoliosis, what's called the type 3 anteverted. Type 3 anteverted is a low-grade pelvic incidence, less than 55, who have curvatures that look like a type 3, but the hips are behind the sacrum. Or they have a pelvic tilt of 0 to negative. You don't want to create type 3 anteverteds. The other kiss of death in my mind is the false type 2. False type 2 is when you have a high grade, someone that should be a 3 or a 4, that has a little bit of thoracic kyphosis, a little bit of lumbar lordosis, and their hips are way out here, and they're compensating through pelvic retrograde. I think that is very bad. We don't have time for it now, but Rusali talks about how each of these types degenerates, and I think considering that and understanding that also helps guide your reconstruction. So what's the goal of the reconstruction, right? It's improvement in symptoms, and we really need durable results. That is the shame of particularly adult spinal deformity surgery. But I again, back to the classifications thing, I have moved away from even liking a distinction between degenerative surgery and spinal deformity surgery. I think that a flat L4, L5 fusion for a degenerative spondylolisthesis will lead to either 3-4 or 5-1 breakdown. And then all of a sudden, that's the patient that says, like, yeah, I had one surgery, now I got to have another, and this is what they said is going to happen. I don't know that that's necessarily what needs to happen if we can determine segmental alignment targets and people. I think that even one segment flat back is really very. We do want to minimize fusion levels. I think that's important to think about as I talk about the rest of this, because I am certainly not advocating that everyone needs T4 to S1. That was a joke in St. Louis that T2 to the sacrum is sometimes the most conservative option. That's a little crazy. That's not how we're thinking. I do think we need to be mindful of the outcome measures that we use to determine what's better in success. I think MIS versus open for single level surgeries, where we talk about blood loss being 150 cc's different, overnight stays versus same day. I don't think they're that important. I certainly think that pushing pushing it, particularly with anesthesia and pain control, so that we can start doing these things outpatient, will make the system more sustainable. But we just need to be careful and keep our eye on the prize that is improved HRQOLs that's durable without reoperations. So the goal of reconstruction, what about age-adjusted alignment targets? Slack and Mundus have heard me talk about this a dozen times. I really, this is a huge, I think this is one of the worst things that we have done in our work. It was initially proposed as targets for HRQOL. So they looked at societal norms for ODI and said, well, if you want an ODI of 40, this is where someone who's 70 will stand. And someone who wants an ODI of 20, this is where they'll stand. First of all, the mathematics of how they did that's not correct. And at face validity, it doesn't really work because spinal degeneration is multifactorial and only partially attributed to age. Age is not static. So you use these categories where 69 and 71 are different, or you operate on someone when they're 45, but their life expectancy is 85. What are you going to do? You're going to go back and take lordosis out? No, of course not. That's insane. It brings to mind the idea of biological versus chronological age, which is something Chris Ames and Fran Felice have talked about quite a bit. But the number of trips around the sun is really irrelevant. In reality, the problem is that age and spinal degeneration go hand in hand. And in their analyses, they did not consider spinal degeneration as a critical confounder. And if you eliminate spinal degeneration, you will see that age is not related to spinal at all. And then the problem comes that this gets peer reviewed and it gets published, so they quote unquote is true. And then we start churn in the papers, right? It suggests decreased rates of PJK and PJF, though I think Greg and I could sit around and make up some random numbers and come up with values in the ISSG database to show that that our made up numbers are true too, because that's essentially what these are. Why is undercorrection bad? It leads to persistent compensatory mechanisms after spinal fusion. So this is a study there's very few, we're working on one with Toronto that's really awesome, that this patient on the left is flat and they're retroverted. You can see their hips are slightly more forward. This arrow here, right? This is important because adjacent segment degeneration, which is, again, it's categories, right? PJK versus ASD, they're the same thing. It's just the magnitude of the failure. They are a result of abnormal shear at the adjacent segment. And as you retrovert, and this spinal fusion mass is moving left, and the rest of the body is going right, you get shear through that disc, and we all know from spondylolisthesis that discs stink in shear. Discs are good in compression, they stink in shear. So next comes the European Spine Study Group, who, and this came about through conversations where they were with Dr. Rousselet, and they wanted to try and objectify the Rousselet classification because his is lots of gestalt, and he says, oh, you just look at it, you know. That's not useful to anybody. One of the main takeaways from the GAP study, Global Alignment Proportion Score, is that they found that older patients were less tolerant of malalignment. It's entirely distinct from the findings of the ISSG age-adjusted alignment group. The external validity of GAP has been challenged time and time again, but it's really the concepts are key. What are some of the important concepts? One is that the outcome measure was no longer health-related quality. PROMs are incredibly difficult to predict. PROMs, the only thing that's highly related to your postoperative PROM is your preoperative PROM. Other than that, I think there are many things, patient expectations, whether it was easy to get a parking spot that day, if their dog just died, all of these other things affect your health-related quality of life that are not captured in x-rays. They also talked about global and regional sagittal plane alignment and lumbar lordosis distribution. So they began to come into this idea of shape of lordosis and magnitude of lordosis. And through the global alignment markers, looking at the thoracic spine. Again, the problem, the external validity of this has been challenged time and time again because one, some of these things are very related. The lordosis distribution index can be a great score if you have a lordosis of 2 degrees with one above, one below, because you have 50% of your lordosis below, but it's not useful because no one wants 2 degrees of lumbar lordosis. And you come back to categories and adding things up. And it doesn't really give you alignment targets. This is all post-operative. We want to be able to do stuff pre-operative. And again, this is the idea of age-adjusted versus gap coming together and sort of having an explosion. This is a 71-year-old whose gap score is 10, which is very bad, but they nail their, excuse me, they nail their age-adjusted sagittal plane alignment targets. Look at that sagittal plane. If you look at the papers, that's on the money. So do you fix them like that and they do well, or do you believe the Europeans and you fix them like that and they do poorly? So that brought me to this study that I did in St. Louis with Jeff Hills. The multi-ethnic alignment normative study was run through EOS, and we had asymptomatic adult volunteers from France, Japan, Tunisia, Singapore, and the United States who got skull to ankle EOS films. And these studies, if you look at age-adjusted, gap was actually the St. Louis patients from this study. And Rousselet, they talk about asymptomatic adults. I don't want asymptomatic adults because we know that degeneration more often than not is asymptomatic. What we wanted was people with no degeneration, no deformity, and somehow your ODI was supposed to be under 20 to get into this group. One person stuck in. So we eliminated everyone with anything that might affect their normal standing alignment. I wanted to see how people actually stood. And we measured everything. And interesting takeaways right away. If you look, this is a PI of 80 on the left, PI of 30 on the right. The L1 pelvic angle is the angle subtended from the middle of the sacrum to the femoral heads to the middle of L1. L1 pelvic angle for this PI of 80 person is 10. L1 pelvic angle for this person with a low PI is -6. The L1 pelvic angle you see is actually a measure of both lordosis magnitude and distribution. But the goal for these people is to normalize their tilts. Look at L1 tilt is the same. T1 tilt only different by 2 degrees, even though their T1 pelvic angles are way off. And if you look at this, 0 degrees, right? This would, and 14, Themi's paper would tell you this might be overcorrected and this is undercorrected by a smidge, when in fact, your T1 pelvic angle is entirely contingent upon your pelvic incidence and shape and distribution of lordosis in your lung. Also, you see here, pelvic tilt for this person with the really low grade PI is very small, 2. If you left them with some deformity with a PT of 18, they'd be very flat. But by the Schwab classification, you'd be muddy, and it's just not right. So I told you, sagittal alignment by age. Look at these flat lines, right? This is age on the x-axis, and your L1, your pelvic angles, lordosis, low lordosis, pelvic tilt. In the absence of deformity or degeneration, sagittal plane alignment is not associated with age. What that tells you is that age-adjusted alignment targets are deformity-adjusted alignment, generation-adjusted alignment targets, which seems very crazy to me. I'll keep moving a little bit faster here. So if we define balance by pelvic incidence alone, what we find is that in all of the studies, if you look up any study that tried to make a prediction model of lumbar lordosis by pelvic incidence, the R squared ends up being around 0.5. R squared is a measure of model fit, and it's how much variation you have around your regression line. A high R squared is good. A R squared of 0.6 with one dependent variable, one independent variable, that's amazing for a biological system. So the R squared is 0.6, and what you will see here is that the prediction interval around that regression is 4 degrees on each side. So if you use half of PI minus 20 and you're within 4 degrees, there's a very high probability that you are going to align that person in some normal type of standard. What's interesting is that the further you get away from the pelvis, the worse it gets, right? R squared is down to 0.45, lots more scatter, lots of people now sort of going above and below the confidence intervals. What if we're now looking at alignment by pelvic incidence alone? Now look at this, right? This is, we talk about 2/3 of your lordosis needing to be low. And then some people say, no, it's just 35 degrees. There's no relationship between pelvic incidence and L5S1 lordosis. The regression line is 25 at that one segment, with that error bar that's about 5 degrees on either side. L4 to S1, still independent of pelvic incidence. Now, like I said, it's closer to sort of 30 to 40. And I think if you're doing a very long segment fusion, then it's okay to say, well, if I'm going to get 35 or 40, I can make it up someplace else. And I'll probably still have a good LPA and a good lumbar lordosis shape and distribution. I think the danger becomes when you start saying, oh, I'm going to do an L4 to S1 for this high-grade spondy on a person with a PI of 75, and I'm going to give them 35 degrees of lordosis. That's going to be flat. And those are the patients that need to be up higher here, closer to this 50 line, which is hard. And you'll see here, right, this is light blue is low pelvic incidence, dark is high pelvic incidence. They're all kind of the same up until L3, which is either where the arc is changing back to kyphotic and very low PIs, or the inflection point's not so much higher. How do you conceptualize this? So this is a pelvic incidence of 40 degrees patient. Lumbar lordosis of 35. If you did PI minus LL, you'd be like, oh, 5 degrees more money. You're very non-money. As I said before, the LL for someone with 40 should be closer to 50 to 55. If you give them all high lordosis, right? Imagine that this is someone who's had a prior fusion flat back, and we do 2 ACRs, which I think in most people's hands, the ACR has kind of gone the way of the dodo bird on this for very rare cases. If you put the lordosis up high and it's too flat, the patient's going to be very forward. The only way for them to get back in the green is to increase their pelvic tilt all the way and to create thoracic hyperextension as compared. If you only put it low, but you're still flat, your L1PA is still going to be too high, and they're going to need to retrovert their pelvis and again extend their thoracic spine. Now you'll see them come to your clinic and they'll be extending their thoracic spine and the hips will be out here and you're like, oh, they have horizontal graze, I nailed it, but it's not true. Really pay attention to the pelvis. What if you get the lordosis right? Again, if you put it in the wrong place, they're still forward. And the only way they can do it is by rocking their pelvis back and creating the shear forces at that adjacent segment. I did all this, I presented it to Larry, and he was like, Mike, this is great, but you're being ridiculous. Like, we want equations and we want categories. This is, you can't, no one's going to use this with all this math and nonsense. So realistically, when you're planning, target lordosis is 60% of the pelvic incidence plus 30. And I do think, actually, if you think about it, the rule of 2/3 of your lordosis low is probably good. And if you're doing a PI of 75 patient, calculate what their lordosis should be, then calculate 2/3 of that if you're going to do an L4S1 and see if you can get it. Because it's all about averages, right? On average, it's 2/3 of lordosis. 2/3 is down low. On average, it's 40 degrees. But what is the average PI is 50, and the average lordosis for someone with a PI of 50 is 60, and 2/3 of that is 40. That's how it works out to 40. So you come back to these averages, which are not that useful, but some useful abstraction for you to think. The L1PA is 50% of PI minus 20. I find this very useful for using in the operating room. Easier than measuring end plates. You can measure the L1PA, make sure it's right. If it's a little overcooked, take some out, take some lordosis out. If it's undercooked, you got to bend more lordosis in. But using this data helps you get the plan. Now, what about the thoracic spotting? What we found was the T4PA was within 4 degrees of the L1PA, with the ultimate goal being a C2 tilt close to 0. The Hewitt wrote a paper from the means group talking about the odontoid hip axis, saying that they want to stand in a straight line. So C2 tilt in the means paper is actually -2 to 2, a very tight range of standing over the hips. Now, does this work, right? This is all like theoretical physics. Does this work? So then we took these concepts to the ISSG database, and we chose only patients fixed from T5 to the sacrum or higher. Not because this is a paper about long segment fusions, but because we needed to control for the things that we can control, right? And modeling T10 of the pelvis is way harder because there are things proximal to that. There's spinal degeneration, paraspinal muscular weakness. We really wanted to look only at the effect of alignment. As your as you deviate from normal for the L1PA, your probability of mechanical failure being pseudarthrosis or PJK goes up. And it's actually it's not 0, right? It's a little positive in the ISSG paper. Then, if you compound that with T4 L1 mismatch, the best you're going to do is nail T4, nail L1PA relationship, and then get your L1PA sort of within 5 degrees of normal. As T4 becomes mismatched, then you really start running risk. And look at, if your T4 is high, your LPA is normal, your risk is about 40%. If they're flat and forward, look at that, you're at 50%. Really, really bad. What about the effect on patient-reported outcomes? This is called a partial effects plot, and this is where we fixed age and preoperative domain scores. And what you see is that as you become more forward, you have a detrimental effect on all of these, right? Rising ODI is bad, falling SRS scores is bad. And all of them are affected by forward sagittal plane alignment, even self-image, because you can't stand up normal. Case examples, preoperative, right? Thoracic degeneration, lumbar hyperlordosis as a compensatory mechanism for the thoracic hyperkyphosis, T4L1 fixed perfectly, L1PA fixed perfectly. The C2 is, I don't know, maybe -2 or -3. This is 2 years out. Preoperative for this one, fixed extremely flat, 6 months, massive PJK. And now also like a big problem to fix. This needs a PSO. And in a lot of hands, this will not get a PSO. This will just get extended to C2. And then you're going to hope on a wish on a star. This also objectifies through sleep classification. Type 1s are very rare. So we actually don't have enough type 1s to really say, but look at their values across the modeled L1PA. Look at the type 2s, type 3s, and type 4. That is a very small sort of scatter around the calculated L1. So how do you use this for surgical planning? This was sent to me by one of my friends up at Mayo Clinic. He said, what do you think I should do? And he kind of immediately said, it needs a PSO. You're not going to be able to get it enough. And he's like, well, what about a 5-1 A-lift? So we modeled it. 25-degree A-lift at 5-1, LPA comes down to 9, when the LPA goal is about 3. So that's not enough. 30-degree A-lift. LPA is still kind of high, and that is a 30-degree A lift. That is something else. That's a big correction. What about a 25-degree A lift, and then you do a T lift up high? You get that maldistribution of lordosis. You can see, look, the LPA has gone up. Less lordosis, low, some in the wrong place, and the LPA has gone up. They're going to retrovert their pelvis. Small A lift, small PSO, you nail the L1 angle. You can also use it in the OR, right? This is a patient with distal junctional kyphosis beneath this extensile cervical fusion and a lumbar flatback with the nice old peak rods. And then notice her SVA is 0. Now this is horrible alignment. So you do a big PSO. It looks like a lot of lordosis, but you measure the L1 pelvic angles. Horizontal gaze is restored. And I think for me, and I know talking with Greg, when you start fixing them like this and their pelvis is like this, these patients are so much better. The people that don't PJK and don't pseudo, but still have pelvic retroversion. So this patient was on OxyContin when she came into the clinic, and at 6 months was off all opioids. She was so much. And again, you really want to avoid the Roussely false type 2. This is a false type 2, right? Hips up hot, hips out front, small lumbar curvature, small thoracic curvature. So it sure seems that restoring the appropriate vertebral pelvic angle seems to minimize mechanical complications, and it does affect problems. So people that say like, oh, sagittal plane alignment doesn't matter for problems, I think that is too dismissive. I think that fixing them flat, even if they don't PJK or have a pseudo, I think it's bad. And I think that what we need to do is figure out individual targets and develop precision medicine for these patients so that we can nail them, whether it is a 4-5 fusion, L4, L5, or T4. Thanks. Guy in the conference room looks like he's about to die.
Yeah, awesome, Mike. Hey, little food for thought. We're starting to do some work on pelvic incidence, and it turns out that there is up to 12 to 15 degrees of motion that can occur post-op in some of these patients. So pelvic incidence, in fact, doesn't look like it's the constant we had hoped it might be with a lot of the work that we've done so far. And even more alarming is if you have a relatively small amount of motion that occurs post-operatively through the SI joints, your pelvic incidence can change such that your global alignment can change up to 5 to 10 centimeters in linear measurements. So it can erode some of the changes we make, meaning even when we target what we think we're targeting, there can be some negative impact from things we haven't accounted for, interestingly. So just food for thought. There were things we were talking about over the weekend in the spinal pelvic study group.
Yeah, I mean, I don't know. I don't believe any of that stuff. I think like if you move that much, I think they're going to have a shitload of pain. 10 degrees, that's a lot of rocking. Just not.
Well, normal joints move 3 degrees, Mike.
3 degrees. Yeah, not 10 or 12 degrees. That's
no, but 3 degrees of rotation, which is how the SI joint moves, at that foundational level has a pretty profound impact upward, as you would guess, right? It's like if you lost 3 degrees of sacral slope, how much, or you gained 3 degrees of sacral slope, that foundational level of change has a pretty profound impact on where your head position is. Right?
Yeah, it'll change your pelvic tilt by 3 degrees.
Right.
But I think that's why, like, especially in long fusions, you have to fix the ilium. When I see these like T10 things, those are
these are with fixed ilia.
Yeah,
these are with pelvic fixation.
The only SI joint I've done 3 SI joint fusions. One was a Charcot, and then 2 were lanky patients with long segment fusions to the sacrum and not to the ilium, and their SI joints got trashed. To your point, that it is the actual only adjacent segment, and then it can really fall apart. One lady, it was unbelievable. One lady was a C2 to the sacrum with those, like, those bicortical, bitriangulate screws.
Yeah.
And it was basically like an internal like pelvic dissociation. I could put a cob into her SI joint and her hemipelvis would flop all over the place.
Crazy.
Yeah, it's crazy. So it's real. I mean, the SI joint moves. It's real.
Great work. Super helpful for us to have all that foundational science you've created.
Right. Good luck to the new fellows.
Thanks, Mike. Appreciate it, buddy. Hey, what do
Any
you
other
what do you
questions
think
from-
about those guys with like bad sacral fractures, like S2 or S3 fractures? You know that the whole sacrum goes into kyphosis.
I mean, I think
How
you
do
got
we
to try to
change our
fix it.
alignment targets?
If you have you got to try to fix it. We did it once with the trauma people where like, if you look up the way Harborview deals with those kyphotic, U-types and stuff like that, femoral traction pins, and you like run it up towards the ceiling and try to flex them down through their pelvis. I think you have to fix it.
Yeah, they're catastrophic.
Yeah, it's a disaster. Really, really
Yeah,
disaster.
Well, thanks for spending
right.
the morning with us, Mike. Appreciate
All
it.
right.
Yeah, thanks,
Have a
buddy.
good day. I'll see you later.
All right.
Your wisdom
Bye.
is appreciated.
Thank you.